Look at this image. This is a microscopic view of Treponema pallidum. It's a thin, spiral, gram-negative spirochete, the sole causative agent of syphilis. You cannot culture this organism in standard laboratory media. That rigid biological constraint forces clinicians to rely entirely on direct clinical signs and serological testing to track its presence. Syphilis is a highly structured progression. An untreated infection unfolds over decades, moving through distinct stages that dictate every single clinical decision. To understand how to diagnose and treat it, we map the infection on a master coordinate plane. On the x-axis, we have time, scaling logarithmically from weeks up to decades. On the y-axis, we plot diagnostic titer strength and disease activity. Clinical presentation, laboratory validity, and pharmacological efficacy are strictly indexed to the age of the infection on this timeline. Misjudging a patient's position on this graph guarantees diagnostic failure and leads to potentially fatal treatment errors. The timeline begins with the primary stage, defined as the 2 to 6 week window following initial inoculation. Here, the disease is strictly localized. The classic presentation is a single, painless, indurated chancre with a cartilaginous edge, accompanied by non-tender regional lymphadenopathy. Without intervention, the spirochete disseminates systemically, pushing the patient into the secondary stage between 6 and 24 weeks. This systemic spread manifests as generalized non-tender lymphadenopathy and a distinct maculopapular rash that characteristically involves the palms and the soles of the feet. In warm, moist areas of the body, patients develop moist, gray-white warty lesions known as conjulotum alata. These lesions carry a very high burden of spirochetes and are extremely infectious. This graph plots the two primary serological curves rising from weeks 2 through 24. The lipoidal curve, tested via VDRL, tracks active disease burden. The treponemal curve, tested via FTA-ABS, confirms lifetime exposure. Once positive, it remains permanently elevated. During secondary syphilis, antibody titers can spike to excessive levels. When this happens, the massive concentration of antibodies actually prevents lattice formation with the antigen. This is the prozone phenomenon, resulting in a false negative VDRL that requires sample dilution to correct. For these early, uncomplicated stages, the pharmacological rule is rigid. A single 2.4 million unit dose of intramuscular benzathine penicillin G is definitively curative. Managing early syphilis is a race to identify these acute, highly transmissible clinical markers before the spirochete retreats into clinical silence. Expanding our x-axis reveals the extended timeline, the latent phase, spanning from under 1 year to well over 1 year, and the tertiary phase, extending 10 to 40 years post-infection. The latent phase is defined by a total lack of clinical manifestations. The infection exists completely out of sight, detectable only by positive serology. The required treatment regimen shifts based on this timeline. Early latent cases, caught under 1 year, still require just 1 penicillin dose. Latent cases, or those of unknown duration, require 3 weekly doses to successfully clear dormant spirochetes. If untreated, the disease advances to the tertiary phase. The benign presentation involves granulomatous lesions called gummas, which appear destructively in the skin, bone, and liver. The fatal manifestation is cardiovascular. The spirochetes trigger endarteritis of the vasa vasorum, leading to saccular aneurysms of the ascending aorta and severe aortic regurgitation. Looking at the timeline over decades, the VDRL curve naturally declines toward baseline, while the FTA-ABS curve remains elevated. Because FTA-ABS is permanently positive, it cannot monitor treatment. Clinicians must confirm a 4-fold decline in VDRL to prove the infection is responding. Tertiary gummas will respond to penicillin, but the structural cardiovascular damage of late syphilis cannot be reversed. Intervention must happen during the latent phase to prevent this permanent destruction. Central nervous system invasion breaks the standard chronological rules. Neurosyphilis can occur at any point on the timeline, from early infection to 30 years later. Early neurosyphilis often presents as meningovascular strokes in young patients, typically involving the middle cerebral artery. Late neurosyphilis targets the structures of the spinal cord and brain. One major late marker is tabes dorsalis. This is posterior column demyelination that causes ataxia, areflexia, and severe shooting lightning pains. The hallmark ocular sign of late neurosyphilis is the Argyll-Robertson pupil. The pupil successfully accommodates to a near stimulus, but completely fails to constrict in reaction to light. Diagnosing CNS involvement creates a paradox in cerebrocerebral fluid analysis. A positive CSF VDRL is diagnostic, but the test is highly insensitive. A CSF FTA ABS test is highly sensitive. A negative result definitively rules out neurosyphilis. This diagram illustrates a critical pharmacokinetic failure. Intramuscular benzathine penicillin G bounces off the blood-brain barrier and cannot achieve treponemocidal concentrations in the cerebrocerebral fluid. Therefore, the absolute treatment mandate for suspected neurosyphilis is continuous IV aqueous penicillin G for 10 to 14 days. This specialized intravenous requirement stands in stark contrast to the standard intramuscular preparations historically and currently utilized for uncomplicated stages. Administering benzathine penicillin for a patient with CNS involvement is a catastrophic error that abandons the brain to progressive destruction. Early maternal syphilis carries a massive transmission risk to the fetus. Prevention follows a rigid timeline. Maternal treatment must occur before the 16th week of gestation to prevent fetal damage. The pharmacological mandate here is absolute. Penicillin is the only option for pregnant patients. Alternative drugs like doxycycline are strictly contraindicated. If transmission occurs, early congenital signs include rhinitis, often called snuffles, and periostitis. Late congenital signs manifest after 2 years of age. The classic presentation of late congenital syphilis is Hutchinson's triad: notched upper incisors, interstitial keratitis, and eighth nerve sensorineural deafness. Whether treating a pregnant patient or an adult in the early stages, clinicians must anticipate the Jarisch-Herxheimer reaction. This is an acute onset of fever, chills, and tachycardia occurring within hours of the first penicillin dose. It is caused by the sudden, simultaneous lysis of spirochetes. It is self-limiting within 24 hours, is not a penicillin allergy, and does not require steroid intervention. Mastering the management of treponema pallidum requires mapping the patient chronologically, matching lipoidal versus treponemal serology to the specific stage, and fiercely respecting the pharmacokinetic boundary of the central nervous system.